Welcome to The Explainer. Today we're diving into ulcerative colitis and Crohn's disease. Now, these two might seem like twins, but they're really more like cousins with very, very different personalities. We're going to break down exactly what sets these two major types of inflammatory bowel disease apart. On the surface, yeah, they look pretty similar. They're both chronic, they both cause inflammation in the gut, and they both follow this really frustrating cycle of flaring up and then calming down. But telling these two cousins apart is absolutely crucial for getting the diagnosis and, more importantly, the treatment right. Okay, so here's our game plan for today. We'll kick things off with what they have in common, then we'll get into the really cool differences, the pattern, the depth, all the clinical clues. And we'll wrap it up by looking at the engine driving all the inflammation. Let's do it. First things first, what do these two actually have in common? Well, they're both chronic inflammatory conditions, right? And there's for sure a genetic thing going on. About 10% of folks with IBD have a family member with it too. And they usually pop up for the first time in young adulthood. And this is really the key experience for anyone living with IBD. It isn't just a constant state of being sick, it's a roller coaster. You have these flare-ups where symptoms are awful, and then you have periods of remission where things are calm. And it's this relapsing and remitting nature that makes managing it a lifelong challenge. Okay, now for the fun part. What's so fascinating is how the inflammation actually lays itself out in the gut. This is probably the single best way to visualize the difference, and we've got a fantastic analogy that will stick in your head, I promise. For ulcerative colitis, or UC, I want you to picture a long, continuous red carpet being rolled out. It always starts in the rectum, and from there, it just spreads upward through the colon in one single uninterrupted sheet of inflammation. There are no healthy gaps, no breaks. And this image shows it perfectly. See how it begins down in the rectum, marked here as A? It can then spread all the way up to involve the entire colon, like you see in C. But the key thing to notice is that it's all one connected, continuous block. Now, Crohn's disease, it's a totally different story. Forget the carpet. For Crohn's, I want you to think of a leaping leopard. Why? Because the inflammation shows up in spots, in patches, and it can be anywhere in the GI tract, literally from the mouth all the way down to the anus. And this is exactly what we mean by that. Doctors call these patches skip lesions. You get a little bit of inflamed tissue, then a stretch of perfectly normal, healthy tissue, and then another patch of inflammation. It just skips around. It's spotty, it's patchy, it really is just like a leopard's coat. All right, so that's the big picture pattern. But the differences don't stop there. What happens when we zoom way in? Let's get out the microscope and take a look at the tissue itself, because there's another huge distinction here. With ulcerative colitis, the inflammation is pretty shallow. It only affects the very top innermost lining of the colon, the mucosa. This superficial damage leads to a classic finding under the microscope called crypt abscesses, which are basically these little glands in the colon getting packed with immune cells. Crohn's, on the other hand, goes deep. The inflammation is transmural. That's the key word. It means it cuts right through all the layers of the intestinal wall, from the inside lining all the way to the outer surface. And this deep, penetrating damage is exactly why Crohn's is tied to much more complex problems like fissures and fistulas. So let's just boil this down. If you're a pathologist looking at a biopsy, this is your cheat sheet. You see superficial inflammation with those cryptobsesses, that just screams ulcerative colitis. But if you see deep transmural inflammation with these little clumps of immune cells called granulomas, that's a classic sign of Crohn's. All right, moving on from the microscope. There are some really important risk factors and symptoms that give us major clues for telling these two apart. And one of the most famous is this bizarre thing called the smoking paradox. Okay, this next part is a huge deal. It's kind of wild, and it's a total classic for any medical exam. For some reason we still don't fully understand, smoking seems to actually be protective against ulcerative colitis. It's mainly a disease of non-smokers. But with Crohn's, it's the complete opposite. It's a major risk factor, and most patients are smokers. And then, of course, you've got the symptoms themselves, which are often a dead giveaway. The absolute hallmark symptom for ulcerative colitis is bloody diarrhea. That's the headline. For Crohn's, it's usually more about that deep abdominal pain and weight loss. And because Crohn's is so deep, transmural, remember, those tougher complications like fistulas and perianal disease are way, way more common. So we've covered the what, the where, and the how. But what about the why? What's actually going on at a molecular level that's causing all this chaos? Let's take a quick look at the inflammatory pathway that drives both of these diseases. It's really like a domino effect. It all starts with some kind of trigger, we're still not totally sure what it is, that flips a switch on the immune cells in your gut, especially cells called macrophages. These macrophages then just dump out a flood of inflammatory signals, these chemicals called cytokines. You've probably heard of the big one, TNF-alpha. These signals just scream for more immune cells to come to the party, and you get stuck in this vicious cycle of chronic inflammation and tissue damage. So let's put it all together for the final showdown. Just remember the key stories. For UC, it's the continuous red carpet only in the colon, it's superficial with crypt abscesses, presents with bloody diarrhea, and it's a disease of non-smokers. For Crohn's, it's the patchy, leaping leopard anywhere in the gut. It's deep and transmural with granulomas, you see more abdominal pain, and there's that strong link to smoking. And that brings us to a final, really important thought. These differences aren't just fun facts for passing a test. They have massive real-world consequences for patients. Think about it. If UC is a continuous disease that's only in the colon, you could, in theory, cure it by surgically removing the colon. But how on earth do you surgically cure a patchy, leaping leopard disease like Crohn's that can pop up anywhere? It's a critical question that doctors and patients face every single day.